offered within the least possible points of care. Next slide. So I've gone through what lives is. I said it is listen, it is inquiring, it is validating, it is enhancing safety and supporting the client. So when we are able to do this, we create a very conducive environment for the client to seek other post-GBV services. Next slide. So if you know anyone experiencing IPV, and now that we're talking about the young people, and I mentioned that they may not come out and tell you, but in the process, even as you're providing other services and you get to know that someone is experiencing violence, we need to remember that all forms of violence are unacceptable. And also ensuring that this person is not alone. And even for us who are listening, if any one of us is experiencing violence, we need to know that violence is unacceptable and you're not alone and it is not your fault and help is available. And this is what we need to reassure our clients. Then we also need to work with them and help identify what is happening and recognize the signs and the cycle of violence. Because when you work with survivors of gender-based violence, you will realize that there's always a pattern and the client will be telling you, this is how it starts, and then it comes to this. So help them to identify so that even when they're enhancing their safety, they have already been able to establish their violence cycles and see how do they work around that to ensure that they are safe. And then work with them and develop a safety plan. Sometimes there are life-threatening situations. There are clients who even come and tell you, he told me if he comes back and finds me in his home, he's going to kill me. Then those are clients that need enhanced safety. So how do we work with them to ensure that they do not go back to that home? And then tomorrow, probably we are reading on the news about our client who came to seek for help. So as healthcare provider, we need to really treat any case of violence as a case that needs to be handled with a lot of care and working with the client to ensure that they are safe. And at any one point, should we try to show the client that that violence is not as serious as they are trying to make it look like. Sometimes you may find someone telling a client, ati hapana, hawezi akakuua. No, if the client is feeling fearful, if they feel they are not safe, then it is our responsibility to help them. And we have support systems, we have referral places, we have shelters. We need to know what is available within our environment so that we have places where we can refer our clients. Next slide. So for survivors of violence, it's also very important to remind our clients that they need to visit the health facility, especially when it is sexual violence, within 72 hours. And we also need to know that there are legal frameworks that can help survivors of violence, and especially intimate partner violence, because sometimes it can get very tricky. And there are things like restraining orders. They can go and make charges to the police station, report, can for separation if it has reached to a point of irreconcilable differences. Then they can also seek civil damages. So they need to know that there are legal avenues to protect them. Let them not just imagine because this is my partner that there's nothing I can do about it. And of course, they need to seek counseling services. I talked about shelters. There are several places where there are shelters for survivors of violence where we can refer them, at least for them to go away from the violence and be safe until the matter is handled. Next slide. So we need to remember, to solve a problem of this magnitude, we need to use an approach that centers the needs of the survivors and priorities. In everything we are doing, it needs to be survivor-centered. If we are providing prevention, we need to know that the survivor has a role to play in this. They are the ones who will know what works best for them. What are the avenues that are there? What are the resources that are available? So we need to use prevention. For prevention, we need to use evidence-based prevention efforts to ensure that the families, the communities, schools, there's all that information available in terms of prevention. For healing, children, adolescents, and adults who experience sexual violence should access child and survivor-centered services. So we need to ensure that our healthcare workers have the skills to work with the children and adolescents who are experiencing violence. And then for justice, children, adolescents, and adults who experience sexual violence should access fair child and survivor-centered justice. So we also need to see how do we work with the legal systems to ensure that cases of violence do not go unattended to, because that is how people get into desperation. And to end the presentation, I have shared some contacts there that we can use to reach out for help. We have the national toll-free line for GBV, which is 1195. LVCT Health runs a telecounseling line, 1190, which provides free counseling services, even for survivors of violence. Then we also have the Red Cross line for a line for reporting cases of violence against children. And then we also have these other lines which can be reached to support survivors of violence. And with that, I come to the end of my presentation. Thank you so much for listening. Asanteni sana.
Thank you very much, Stella, for the elaborate presentation. Indeed, it was very, very informative. Thank you. And maybe just to note that the adolescents and young people are likely to be undergoing all the 4 forms of violence. They could be undergoing sexual violence, physical violence, emotional and economic violence, especially taking into consideration that they may not even have a source of income. So they could be depending on the very person who is abusing them for economic support. So thank you very much. That was a very informative presentation. I think we can move to the questions section. And there are quite a number of questions for Professor Ogutu. And I can see one question for Stella. And if anyone has a question, you can either put it on the chat or you raise your hand, and then we'll see it, and then we'll give you a chance to ask the question. So I'll go to one question that's coming for Stella before we go to Prof. Ogutu for his questions. What explanation do we assign to finding that boys incur more emotional violence compared to girls? That is coming from Wilkista of Bindi. Stella, are you able to answer that question from Wilkista? What explanation do we assign to the findings that boys incur more emotional violence compared to girls? Stella?
Thank you so much for the question. And with me, I have my colleague, Michael Gaido, who will also help me in responding to the questions. So hosts, if Michael Gaido raises his hand, kindly unmute him so that he can help in answering some of the questions that will be coming up. So thank you so much for your question. And indeed, from the survey, it shows that boys were experiencing more emotional violence than the girls. And for me, maybe I would just put it to the issue of the masculinity norms, where probably men or boys have been taught not to talk about their problems. And sometimes they may just keep quiet about the issues. And not until maybe a survey comes up. And because the survey was conducted in a very professional manner, the people who are asking the questions were probably trained psychologists or trained counselors. So they create an environment where the boys will be able to talk about their issues more openly. And not saying that girls do not also experience emotional violence, but I'm looking at it from that perspective, that probably because of the issue of the boys being expected to remain strong and to remain macho, they may just be dying silently and quietly. And even through interactions with most of the men, you will find that they have a lot of unfinished business from their childhood. And it's only when they grow up, they realize this was happening to me and it was not right. So I think for me, that is how I would put it. And my colleague, Michael, probably if you are on air, you can add something.
Stella, thanks. Just to note that during the survey, men tended to ask the boys questions. If you compare with the girls who were interviewed by the girls. So for this case, and it's also a learning space to learn, to understand that even in future, in surveys that target to ask questions specifically for certain gender, you may get more information of what you're intending to look for if you give them a safe space and people that they can, relate to. So that give an opportunity for answers to come in that format for the boys. Those are the submissions over, unless if there's any other question to address.
Yeah, thank you very much, Michael. I don't see another question for Stella, so we can move straight to Prof. Ogutu's questions. And the first question for Prof. Ogutu is, kindly talk about the use of combined oral contraceptives versus cyclical progesterone from the 16 to 25 of the cycle in minors with dysmenorrhea and heavy bleeding when tranexamic and constant combo does not work. That is coming from Dr. Mutindi Kakuti. Maybe I allow Prof to answer that question first, then we can go to the second one. Prof. Ogutu. Prof. I don't know if Prof can hear me. I think I noticed that Prof is either he has dropped off. I don't see him. I think Prof is not here with us, Dr. Kennethia. And I believe there are probably other gynecologists in the house who may attempt to answer that question. So
I can try.
Yes, Dr. Ann Kihara. Karibu.
Yes, thank you very much for that question. Most of the ladies who have polycystic ovarian disease, the biggest problem is you have, if you remember what Prof showed you, the cycle with menses, your first half before you release your eggs is mainly estrogen. The second half of your cycle, which is after ovulation, you then have a combination of estrogen, but more so progesterone. So what happens with people with polycystic ovarian disease, they tend to just have estrogen-laden cycles. The second half does not seem to work properly. So when you introduce progesterone, then you will end up with a withdrawal bleed, simulating now or mimicking now what would look like your normal menstrual cycle. So for some ladies, and particularly those who are not interested in a pregnancy, what we normally do is then give them the combined pill, which has estrogen and progesterone. So the cyclicity of that cycle becomes normal. But you need to be very clear. One, she's not interested in pregnancy. The other way we also address polycystic ovarian syndrome amongst these girls is ask them to lose some weight, because we know fatty tissue tends to have more estrogen in it. And this is even one of the reasons why, even as we get closer to menopause, you tend to find the middle area of a lot of women getting a little bulkier, because that is their source of estrogen. So when you ask them to lose some weight, you actually find the periods then tend to normalize. So here, yes, combined oral contraceptives is one way, which is the hormonal correction. The tranexamic acid that you're using is actually to cut off the excessive bleeding, because we do know tranexamic acid has a role with the clotting system. So it actually facilitates in reduction of excessive blood flow. The NSAIDs is to deal with the cramping. These are the painkillers that we normally also concurrently give, what Prof was calling dysmenorrhea. The cramping is actually reduced by NSAIDs or even other drugs that are anxiolytics. So that's how I'd respond to that question.
Sorry, I'm back. I had a problem with the logging. Sorry for that.
Thank you, Prof.
Sorry for that.
Okay, welcome back.
At least I'm able to get back. There was a problem with my logging system. So I have to change to the phone. Okay.
Okay, thank you very much, Professor Ogutu. You are back now. There are still two more questions that you will answer. Another question is coming from Gladys Murugo. She is asking, there's a rise in the number of ladies coming out about the fight with endometriosis. Is there a way of identifying how to assist them through the early identification? Any training offered to help the girls know how to deal with the pain early to ensure it does not get worse with age? So that's the question around endometriosis.
Okay, what I would need to answer is that endometriosis is a complex. It's a complex entity, and it is not a simple thing because it involves a lot of other issues, and then it will depend on what stage of endometriosis are you dealing with. Now, when you come to the young girls, one thing we need to know is that for a long time, it used to be said that endometriosis is not seen in the young girls, endometriosis is not seen in the Africans, endometriosis is not seen in the developing world. That is not true. The only thing you need to know is that, remember when you're talking of endometriosis, remember dysmenorrhea. We are looking at the primary and secondary. Primary, there's no obvious pelvic cause, which is what is in the reproductive tract, and especially in the uterus. When you're dealing with endometriosis, this now brings you to the second group of secondary dysmenorrhea. And it is a diagnosis you're trying to exclude and see where else. So when a patient or a young girl is complaining of pelvic pain, especially related to menses, the key thing is go to a clinician, preferably a gynae, or go to any doctor who is comfortable with looking after the patient, the young girl, so that you can be able to look at what are some of the possible causes of endometriosis. There are some which can be quite classical, maybe if they're having bleeding points, maybe around some around the breast, some maybe around the navel. But there are basic ways of being able to examine this patient. The gold standard would be to do a laparoscopy to try and check and see if you can be able to pick up the endometrioma. Sometimes if you have got very good ultrasound, I mean, if you do an MRI, you may be able to pick up some of the sites, and therefore you suspect that you are having endometriosis. At times, because of these young girls, and if somebody has got a very high index of suspicion, you may put them on some medication, like the progesterone medication. You can start them on the pill, you can give them just the ordinary analgesics, or you can use the design to try and see if you can be able to minimize some of the symptoms in these patients. It's a question of looking at what exactly could be the cause. You exclude all the other secondary causes, but the gold standard would be do an ultrasound, do laparoscopy. You can pick up the endometrioma, subject them to histology, then you'll get a confirmation that you're dealing with endometriosis. Word of caution, not every young girl who has got menstrual pain and who can't pick up the cause may be endometriosis. Some patients just have adenomyosis, and the adenomyosis because you have got a problem with the spiral arteries within the ovary, within the uterine wall, and that can give somebody very severe pain. No wonder sometimes some of the medication you'd use to take care of early stages of endometriosis can even respond very well, especially the adenomyosis may respond very well. But my parting word is that high index of suspicion, do a proper investigation before you label somebody that you have endometriosis, because most of the people use it as a stigma. oh, I have endometriosis, it means I want to get pregnant, it means this and this, it means that and that. So be careful in the choice of words unless you're sure of your diagnosis. Asante.
Thank you very much, Prof. You have one more question. There is a question around the polycystic. I think it's polycystic ovarian disease. Thank you for this information. My question is: those young girls, young ladies diagnosed with PCOS and currently under drugs like contraceptives, do they take them for the rest of their life, or? That is the question from Phoebe Abonyo. Prof.
Okay. First of all, a few things about polycystic, the so-called polycystic ovarian disease. At times you have got an unusually high numbers of diagnoses of patients with polycystic ovarian disease, which are actually not true. Now, patient is sent for an ultrasound. Ultrasound is done. The gentleman from the ultrasound writes for you, oh, I can see multicentric cysts at the periphery. They are small, less than 12 millimeters in diameter. They are multiple size. Therefore, this is polycystic ovarian disease. No, that is polycystic ovarian morphology as depicted on the ultrasound. There are many other things which have to be in place for you to start talking about polycystic ovarian disease. You have to look at the history of this patient, look at the menstrual pattern, the regularity, the volume, the duration of flow, and the pain associated with it, okay? And then the other symptoms. The other classical thing which is important in this patient is that you look at the AMH, anti-Mullerian hormone. It's usually elevated. Why? Because when you have got these small multiple cysts, ovulation doesn't take place because these cysts do not have the necessary component of interplay of the estrogen progesterone, FSH, LH levels for you to be able to ovulate. So eventually, after some time, when you do your AMH, the body recognizes that you are having multiple follicles. And when you have multiple follicles, it responds, it gives you an impression that you have got so many follicles that this ovary is hyperactive. No wonder you get your very high AMH levels, even higher than the normal figure. That's why high AMH levels is one of the things looked at the gold standard. So you want to look at what is the interplay in this patient. Contraceptive, okay, we call them contraceptive pills, is used to treat this patient so that you can be able to minimize the development of the follicle so that you don't have those multiple follicles. What we want you to take home is that don't say that this patient is on a contraceptive. That is the wrong word which mothers will tell you, my daughter cannot be on contraceptive pills. You tell them that we're using combined hormones to be able to correct the abnormality we are seeing. So you can use that. Sometimes you need to use medication which will be able to ensure that the glucose metabolism at the level of the ovaries, which is one of the major contributors to having these multiple cysts. There are medications you can use which will help at that point in time and therefore ensure that the growth of the follicles is realized to the optimum size whereby ovulation now takes place. So using combined oral contraceptives is just a stopgap because you're trying to minimize the development of the follicles so that you don't have multiple follicles. And then when we draw it, you get bleed from the endometrial lining so that you get regularity in bleed, but it doesn't necessarily correct it. You need to correct the metabolic pathways at the ovarian side. So there are medications which have got things with inositol, which can be able to be used to help get regularity at that point in time. So the subject of polycystic ovary is very complex, and it is almost like a syndrome. Many things, each and every patient should be treated differently. One patient will respond to the combined combined estrogen progestogen medication, another will not. Some may just respond to progestogen only. So that patient has to be looked at individually so that you decide what exactly is good for this patient. But they must be investigated to rule out all other malady which might many widely accepted. Hello.
Thank you very much, Prof, for the responses to the questions. I believe that we don't have any more questions, and the participants are satisfied with the responses they have received. Yes. The other question I see is whether people will get presentations. Just to let you know that they will seek consent from the presenters, whether to share the presentations, and if they get the consent, I'm informed that they are going to be put in the KNH repository for anyone who wants to download. So we come to the end of the symposium for today. Like I said, we are not going to be able to have two presenters, and their presentations will be scheduled for tomorrow. So I will, at this juncture, hand over to Anne, Dr. Anne Kihara or John Kinuthia to give their final remarks. But before I do that, just to ask the presenters if they have any additional comments they would want to make in regard to the questions or to any comment they would like to add. The two presenters, Professor Ogutu or Stella. Any comments from Prof. Ogutu or any addition before we close?
Nothing maybe, but just to say that this is an opening whereby we should be having frequent interactions, especially on topical issues, because remember nowadays we don't have many of those formal meetings. So instead of having just a single topic, having topical issues like this is very informative, and we are able to interact. And we also get questions from the audience, and this just helps to improve knowledge and care of the women in our region. Thank you, and thank you for the organizers, Anne and Kinuthia, for giving me the opportunity to lead this session, and also having been given the opportunity to present on this topical issue of menstrual disorders, especially in the adolescent. Thank you so much. And God bless.
Thank you very much, Prof. Ogutu. We go to Stella. Stella, do you have any final remarks before we close?
Thank you so much. I think I'll also appreciate the organizers for giving me the opportunity to share the information that I have. And just to mention to the participants, it is very, very important for us to really look out for any signs of our clients experiencing violence, either through having a discussion with them or looking at signs and symptoms. And I've seen someone on the chat who said they're the psychologist, counselor, and one thing that one needs to look out for is even clients who come to the clinic in the same clothes. And that could even be a good sign to show probably their basic needs are not being addressed. So even as we are attending our clients, let's get to look out for things that they might not be telling us, because clients who experience violence are already too traumatized, and it's only a conducive, friendly environment that will help them to speak out. So let's be warm, let's be very open to them, tell them that we are able to support them, because very, very many people are suffering very many health issues as a result of violence. And they reach out, they will come to your clinic over and over again just to see whether you can notice there's something that is not okay with them. So screening for violence is important, and just having a discussion with our clients. Thank you so much and enjoy your evening.
Okay, thank you very much, Stella. The two presentations were very informative. Thank you very much, Prof. Ogutu and Stella, for that. We move on, and I'm going to be handing over the meeting to Dr. Ann Kihara to just do the final closing remarks, and as we finish. Thank you.
Thank you very much, Anne Mwangi and Professor Mondi Ogutu, for moderating this session, and for Professor Mondi Ogutu and Stella and her colleague for making the presentation. We've been told from the two presentations, high index of suspicion if it is GBV, high index of suspicion if you're dealing with a normal cycle or an abnormal menstrual cycle. Make sure you examine, but in your examination for both, be very empathetic and cognizant of their age. And the care eventually must be individually tailored. That has come very strongly from both of them. My only passing shot, and I think we need to really begin to put a high index of suspicion, especially from the COVID era, is the use of the social networks we have, the tweets, the blogs, the WhatsApp, and kadhalika, as tools of violation, particularly for the younger age. It is something that's increasing, and it also includes photography. So the photography and the pornography that's going in the back doors, and you know, and I know, a lot of the teenagers tend to be cooped up in their rooms. Can we be a little bit more diligent in knowing what's happening also behind closed doors with the mobile phones and the videos and, you know, the movies that they tend to be watching, even as we tend to be moving about our businesses. So with that, I think we've had a very good day. We welcome you again tomorrow at 2 o'clock. It'll be even more exciting. We'll be tackling HIV. And I know that is a major, major, major area of concern, STIs and HIV. So you're most welcome tomorrow at 2 o'clock. Let's all meet there. Thank you very much and have a blessed evening.
Thank you very much, everyone, and have a good evening. See you tomorrow.
Okay, bye.